HSM 801, page 849, Global Health by Dr. I.D. Alabere Emena. Outline, concepts, history, standing theories, the United Nations system, international health organizations and agencies, international health regulations. Concepts in global health. Global health is the health of populations in the global context. Global health, sometimes referred to as international health, geographic medicine, international medicine. It is a field of healthcare, usually with a public health emphasis, dealing with health across regional or national boundaries. It has been defined as the area of study, research, and practice that places a priority on improving health and achieving equity in health for all people worldwide. Problems that transcend national borders, or have a global political and economic impact are often emphasized. Thus, global health is about worldwide health improvements, including mental health, reduction of disparities, and protection against global threats that disregard national borders. Global health can be measured as a function of various global diseases and their prevalence in the world and threats to decrease life in the present day. The predominant agency associated with global health is the World Health Organization. Other important agencies impacting global health include UNICEF and World Food Programme. The United Nations system has also played a part with cross-sectoral actions to address global health and its underlying socio-economic determinants with the declaration of the Millennium Development Goals and the more recent Sustainable Development Goals. Global health employs several perspectives that focus on the determinants and distribution of health in international context. Some of these are: 1. Medicine describes the pathology of diseases and promotes prevention, diagnosis, and treatment. 2. Public health emphasizes the health of populations. 3. Epidemiology helps identify risk factors and causes of health problems. 4. Demography provides data for policy decisions. 5. Economics emphasizes the cost-effectiveness and cost-benefit approaches for the optimal allocation of health resources. 6. Other social sciences such as sociology, development studies, psychology, anthropology, cultural studies, and law can help understand the determinants of health in societies. History of global health. The 19th century held major discoveries in health and public health. The Broad Street cholera outbreak of 1845 was central to the development of modern epidemiology. John Snow. The microorganisms responsible for malaria and tuberculosis were identified in 1880 and 1882, respectively. So malaria 1880, tuberculosis 1882. The 20th century saw the development of preventive and curative treatments for many diseases, including the BCG vaccine for tuberculosis and penicillin in the 1920s. The eradication of smallpox, with the last naturally occurring case recorded in 1977, raised hope that other diseases would be eradicated as well. Important steps were taken towards global cooperation in health with the formation of the United Nations and the World Bank Group in 1945 after the World War II. A cholera epidemic that took 20,000 lives in Egypt in 1947 and 1948 helped spur the international community to action. In 1948, the member states of the newly formed United Nations gathered to create the World Health Organization. The WHO pushed its model list of essential medicines, and the 1978 Alma Ata Declaration underlined the importance of primary health care. At a United Nations summit in 2000, member nations declared 8 Millennium Development Goals (MDGs), which reflected the major challenges facing human development globally to be achieved by 2015. The declaration was matched by unprecedented global investment by donor and recipient countries. According to the UN, these MDGs provided an important framework for development, and significant progress was made in a number of areas. However, progress was uneven, and some of the MDGs were not fully realized, including maternal, newborn, and child health, as well as reproductive health in some countries, particularly developing countries, including Nigeria. Building on the MDGs, a new strategy, the Sustainable Development Agenda with 17 Sustainable Development Goals (SDGs) has been established for the years 2016 to 2030, the first goal being an ambitious and historic pledge to end poverty. On 25 September 2015, the 193 countries of the United Nations General Assembly adopted the 2030 Development Agenda titled Transforming Our World, the 2030 Agenda for Sustainable Development. Measures of global health and health interventions. Measures of global health include 1. Disability adjusted life year, DALY. 2. Quality adjusted life years, QALYs. And 3. Mortality rates. Disability adjusted life years. Disability adjusted life year, DALY, is a measure of overall disease burden expressed as the number of years lost due to ill health, disability, or early death. The disability adjusted life year is a societal measure of the disease or disability burden in populations. DALYs are calculated by combining measures of life expectancy as well as the adjusted quality of life during a burdensome disease or disability for a population. It was developed in the 1990s as a way of comparing the overall health and life expectancy of different countries. The DALYs have become increasingly common in the field of public health and health impact assessment, HIA. It not only includes the potential years of life lost due to premature death, but also includes equivalent years of healthy life lost by virtue of being in states of poor health or disability. In so doing, mortality and morbidity are combined into a single common metric. DALYs are years of healthy life lost. The DALY is a summary measure that combines the impacts of illness, disability, and mortality by measuring the time lived with disability and the time lost due to premature morbidity. Due to time lost due to premature mortality. One DALY can be thought of as 1 year was one lost year of healthy life. The DALY for a disease is the sum of the years of life lost due to premature mortality and the years of life lost due to disability for incident cases of the health condition. Disability adjusted life years. The overall burden of disease is assessed using the disability adjusted life years, DALY, a time-based measure that combines years of life lost due to premature mortality, YLLs, and years of life lost due to time lived in states of less than full health or years of healthy life lost due to disability, YLDs. One DALY represents the loss of the equivalent of 1 year of full health. Using DALYs, the burden of diseases that cause premature death but little disability, such as drowning or measles, can be compared to that of diseases that do not cause death but do cause disability, such as cataracts causing blindness. Example of DALYs. The death of a 15-year-old boy in a road traffic accident who was very healthy has no years lost to disability, as the accident was sudden and he was previously in perfect health. In calculating his DALYs, it is to be assumed that he would have lived for 80 years if not for the accident that caused his death. Based on the foregoing, his DALYs will be 80 minus 15 equal to 65 DALYs. Quality adjusted life years. Quality adjusted life years, QALY, is a generic measure of disease burden including both the quality and quantity of the life lived. It is used in economic evaluation to assess the value of medical interventions. One QALY equates to 1 year in perfect health. QALY scores range from 0 for death to 1 for perfect health. QALYs can be used to inform health insurance coverage determinations, treatment decisions, to evaluate programs, and to set priorities for future programs. The QALY is a measure of the value of health outcomes to the people who experience them. It combines two different benefits of treatment, length of life and quality of life, into a single number that can be compared across different types of treatments. QALYs combine expected survival with expected quality of life into a single number. If an additional year of healthy life is worth a value of 1 year, then a year of less healthy life is worth less than 1 year. QALY calculations are based on measurements of the value that individuals place on expected years of survival. QALYs are years of healthy life lived. Measurements can be made in several ways. 1. By techniques that stimulate gambles about preferences for alternative states of health, with surveys or analysis that infer willingness to pay for alternative states of health or through instruments that are based on trading off some or all key likely survival time that a medical intervention might provide in order to gain less survival time of higher quality. Infant and child mortality. Infant mortality and child mortality for children under age 5 are more specific than DALYs or QALYs in representing the health in the poorest sections of a population and are thus especially useful when focusing on health. Morbidity. Morbidity measures include incidence rate 1, 2, prevalence, and 3, cumulative incidence, with incidence rate referring to the risk of developing a new health condition within a specified period of time in a defined population, while prevalence rate refers to all cases, that is both old and new cases, within a specified period of time in a defined population. Although sometimes loosely expressed simply as the number of new cases during a time period, morbidity is better expressed as a proportion or a rate. Health interventions. Global interventions for improved child health and survival include 1. The promotion of breastfeeding. 2. Zinc supplementation. 3. Vitamin A fortification. 4. Salt iodization. 5. Hygiene interventions such as hand washing, vaccinations, and treatments of severe acute. Hygiene interventions such as hand washing. 5. 6. Vaccinations. And 7. Treatments of severe acute malnutrition. Theories of global health. There are several theories related to global health and related interventions and implementations. 4 social theories are considered by several scholars as prominent. 1. The theory of unintended consequences of purposive (social) action. 2. The theory of social construction of reality. 3. The theory of social construction. 3. The theory of social suffering. 4. The concept of biopower. So look at them one after the other. Theory of unintended consequences of purported (social) action. The first social theory of global health is the unintended consequences of purposive (or social) action, which was introduced by the sociologist Morobot Merton, Merton. This theory holds that all social interventions have unintended consequences, some of which can be foreseen and prevented, whereas others cannot be predicted. Therefore, all social actions need to be routinely evaluated for unintended consequences that might lead to the modification of the program, and if the consequences are serious enough, their termination. This theory will seem to be the social science equivalent of medicine's ethical practice of do no harm, but it goes beyond to reason that every action can have unintended effects, and also that certain of those may not necessarily be harmful. Global health is filled with illustrations of unintended and often harmful consequences of programs, such as those following coercive vaccination during the smallpox eradication campaigns in India, which led to individual and community resistance to later vaccination campaigns. An unintended consequence of China's one-child per family population control policy is the sexual revolution it created. The theory of social construction of reality. The second social theory of global health is the social construction of reality, as introduced by Peter Berger and Thomas Luckmann in 1960s. Berger is Berger, Thomas Luckmann, Luckmann, in the 1960s, that has become foundational in the social sciences. This theory holds that the real world, no matter its material basis, is also made over into socially and culturally legitimated ideas, practices, and things. It means that people shape their experiences through social interactions. They argued that society is created by humans and human interactions, which they called habitualization. Habitualization describes how any action that is repeated frequently becomes cast into a pattern, which can then be performed again in the future in the same manner. They posited that not only do we construct our own society, but we also accept it as it is because others have created it before us. It thus becomes the norm. Hence, the spread of the H1N1 influenza virus is made over globally into the socially threatening and culturally fearful swine flu epidemic. Cancer takes on the meaning as the dread disease in the USA in the early 20th century. Mental illness is stigmatized by the social construction of non-persons in most countries. A formerly authoritarian physician-patient relationship becomes increasingly egalitarian as cultural expectations change and medications take on a social life of their own via informal networks and social marketing. Abortion becomes highly contentious in the USA but not in Japan, just as brain death becomes highly contentious in Japan but not in the USA. Global health problems and programs can and at most times do take on culturally distinctive significance in different local settings. This leads to a tension between global policies and local reality that is foundational to medical and public health practice. A corollary of the social construction of reality is that each local world, a neighborhood, a village, a hospital, a network of practitioners/researchers realizes values that amount to a local moral context that influences the behavior of its members. For global health, The implication is that those local moral wars can affect everything from smoking cessation interventions to HIV/AIDS prevention and treatment programs. The theory of social suffering. The third social theory is that of social suffering, which provides a framework that holds 4 potentially useful implications for global health. 1. First, that socio-economic and socio-political forces can at times cause disease, as is the case with the structural deep poverty, creating the conditions for tuberculosis to flourish and for antibiotic resistance to develop. Number two, that social institutions such as healthcare bureaucracies that are developed to respond to suffering can make suffering worse. Examples of these are hospital-based medical errors or the failure of the clinicians to adequately diagnose and treat illnesses. 3. Social suffering conveys the idea that the pain and suffering of a disorder are not limited to the individual sufferer, but extend at times to the family and social network, as is the case when Alzheimer's disease created serious cognitive impairment in the patient that he or she expresses no discomfort about, while the adult children experience deep loss and frustration. For global health programs, the implication is that the family and network may also be in need of health interventions and are often influential in help seeking and adherence. Number 4, finally, the theory of social suffering collapses the historical distinction between what is a health problem and what is a social problem by framing conditions that are both and that require both health and social policies, such as in urban slums and shanty towns where poverty, broken families, and a high risk of violence are also the settings, where depression, suicide, post-traumatic stress disorder, and drug misuse cluster. Although there are clearly occasions when health policy and social policy have different targets in the poorest of communities, the medical, the economic, and the political may often be inseparable. The concept of biopower. The fourth social theory on global health is the biopower concept, a term coined by Michael Foucault, Foucault, to model the way political governance increasingly exerted its effects via the control of bodies and populations. This concept refers to various means by which nation-states control their populations. It refers to practices of public health, regulation of heredity, and risk regulation, among many other regulatory mechanisms that are often linked less directly with physical health. Biopower relates to the practice of modern nation-states and their regulation of their subjects through an explosion of numerous and diverse techniques for achieving the subjugations of bodies and the control of populations. Biopower is a technology of power for managing humans in large groups. The distinctive quality of this political technology is that it allows for the control of entire populations. Governments control population through the use of knowledge and systems that grant them surveillance. Individuals internalize the state's control by regulating their actions in acknowledgement of being monitored. Social statistics in Europe grew out of the state's effort to enumerate populations for purposes of social control, albeit that effort also had health-relevant consequences. Other examples include the way that during the era of radical collectivization under Maoist policies in China in the 1960s and 1970s, the population control policy led to local cadres requiring village women in their reproductive years to post the dates of the menstrual cycle on the doors of their homes as a means of surveillance and birth control. Working with this theory, Adriana Petrina introduced the term biological citizenship to make sense of the post-Chernobyl disaster situation in the Ukraine. Although radiation scientists certified only a few hundred victims of radiation exposure, a much greater number of people claimed disability from the accident, and in the process a new identity, citizens biologically defined by this trauma as deserving of compensation from a caring state that exerts the power of governance via the welfare roles. The United Nations system. The United Nations system includes the United Nations and its subsidiary bodies such as the separately administered funds and programs, research and training institutes, and other subsidiary entities, specialized agencies, and affiliated organizations. Some of the organizations of the United Nations predate the founding of the United Nations in 1945 and were inherited after the dissolution of the League of Nations. The United Nations consists of the United Nations and the 6 principal organs of the United Nations. 1. The General Assembly. 2. The Security Council. 3. Economic and Social Council, ECOSOC. 4. Trusteeship Council. 5. International Court of Justice, ICJ. 6. The United Nations UN Secretariat. Additionally, there are various specialized agencies and affiliated organizations. The executive heads of some of the United Nations system organizations and the World Trade Organization, which is not formally part of the United Nations system, have seats on the United Nations system Chief Executive Board for Coordination, CEB. This body, chaired by the Secretary General of the United Nations, meets twice a year to coordinate the work of the organizations of the United Nations system. General Assembly. United Nations General Assembly, UNGA/GA, consists of all United Nations member states and meets in regular session once a year under a president elected from among the representatives. Its powers are: 1. To oversee the budget of the United Nations. 2. To appoint non-permanent members to the Security Council. 3. To receive reports from other parts of the United Nations and make recommendations in the form of General Assembly resolutions. It has also established a wide number of subsidiary organs. Security Council. The United Nations Security Council, UNSC, is charged with the maintenance of international peace and security. Its powers outlined in the United Nations Charter include: 1. The establishment of peacekeeping operations. 2. The establishment of international sanctions. 3. The authorization of military action. Its powers are exercised through the United Nations Security Council resolutions. The Security Council held its first ever session on 17 January 1946 at Church House, Westminster, London. Since its first meeting, the Council, which exists in continuous session, has traveled widely, holding meetings in many cities such as Paris and Addis Ababa, as well as its current permanent home at the United Nations headquarters in New York City. So United Nations headquarters is in New York City. There are 15 members of the Security Council, consisting of 1. 5 veto-wielding permanent members: China, France, Russia, United Kingdom, the United States. 2. 10 elected non-permanent voters with 2 terms. 10 elected non-permanent voters with 2 terms. Then this basic structure is set out in Chapter 5 of the UN Charter. The Security Council members must always be present at the UN headquarters in New York so that the Security Council can meet at any time. Economic and Social Council. The United Nations Economic and Social Council, ECOSOC, is responsible for coordinating the economic, social, and related work of the 15 United Nations specialized agencies, their functional commissions, and 5 regional commissions. ECOSOC has 54 members and holds a 4-week session each year in July. Since 1998, it has also held a meeting each April with finance ministers heading key committees of the World Bank and the International Monetary Fund, IMF. The ECOSOC serves as a central forum for discussing international economic and social issues and for formulating policy recommendations addressing to So like I said, the ECOSOC serves as the central forum for discussing international economic and social issues and for formulating policy recommendations addressed to member states and the United Nations System Secretariat. United Nations Secretariat is headed by the United Nations Secretary General, assisted by staff of the International Civil Servants worldwide. It provides studies, information, and facilities needed by the United Nations bodies for their meetings. It also carries out tasks as directed by the UN Security Council, the UN General Assembly, the UN Economic and Social Council, and other UN bodies. United Nations Charter provides that the staff are to be chosen by application of the highest standards of efficiency, competence, and integrity with due regard for the importance of recruiting on a wide geographical basis. The UN Charter provides that the staff shall not seek or receive instructions from any authority other than the UN. Secretary General alone is responsible for staff selection. International Court of Justice. The International Court of Justice, sometimes called the World Court, is the primary judicial organ of the United Nations. It is the most supreme court in the world. It is based in the Peace Palace in The Hague, Netherlands, making it the only principal UN organ not located in New York City. Its main functions are to settle legal disputes submitted to it by states and to provide advisory opinions on legal questions submitted to it by duly authorized international organs, agencies, and the UN General Assembly. Its opinions and rulings serve as sources of international law. The ICJ is the successor of the Permanent Court of Handover. The ICJ is the successor of the Permanent Court of International Justice (PCIJ), which was established by the League of Nations in 1920. After the Second World War, both the League and the PCIJ were succeeded by the United Nations and the ICJ, respectively. The statute of the ICJ draws heavily on that of its predecessor, and the latter's decisions remain valid. All the members of the UN are parties to the ICJ statute. The ICJ comprises a panel of 15 judges elected by General Assembly and Security Council for 9-year terms. Its official working languages are English and French. Trusteeship Council. The United Nations Trusteeship Council, one of the principal organs of the United Nations, was established to ensure that trust territories were administered in the best interests of the inhabitants and of international peace and security. The trust territories, most of them are former mandates of the League of Nations or territories taken from nations defeated at the end of World War II, have all now attained self-government or independence, either as separate nations or by joining neighboring independent countries. The last was Palau, a formerly part of the trust territory of the Pacific Island, which became a member state of the United Nations in December 1994. Specialized agencies of the United Nations. The specialized agencies are the autonomous organizations working with the United Nations and each other through coordinating machinery of the Economic and Social Council. Each was integrated into the UN system by way of agreement with the UN Charter Article 57. So, United Nations agencies, there are 16 here. 1. Food and Agriculture Organization, FAO. 2. International Civil Aviation Organization, ICAO. 3. International Fund for Agricultural Development, IFAD. 4. International Labour Organization, ILO. 5. International Maritime Organization, IMO. 6. International Monetary Fund, IMF. 7. International Telecommunication Union, ITU. 8. United Nations Education, Scientific and Cultural Organization, UNESCO. 9. United Nations Industrial Development Organization, UNIDO. 10. Universal Postal Union, UPU. 11. World Bank Group, WBG. 12. World Health Organization, WHO. 13. World Intellectual Property Organization, WIPO. 14. World Meteorological Organization, WMO. 15. World Tourism Organization, UNWTO. 16. International Refugee Organization, IRO, ceased to exist in 1952. Specialized agencies continued. World Bank Group, International Bank for Reconstruction and Development, National Center for Settlement of Investment Disputes, International Development Association, IDA, International Finance Corporation, IFC, Multilateral Investment Guarantee Agency, MIGA, Research and Training Institutes. The various research and training institutes were established by the General Assembly to perform independent research and training. 1. United Nations Institute for Disarmament Research, UNIDIR. 2. United Nations Institute for Training and Research, UNITAR. 3. United Nations Inter-Regional Crime and Justice Research Institute. 4. United Nations Research Institute for Social Development, UNRISD. 5. The United Nations International Research and Training Institute for the Advancement of Women, INSTRAW, was merged with other elements of the United Nations system into a new organization, UN Women, in January 2011. Other entities: United Nations Children Fund, Joint United Nations Program on HIV/AIDS, UNAIDS, United Nations International Strategy for Disaster Reduction, UNISDR, United Nations Office for Project Services, UNOPS, United Nations Office of Internal Oversight Services, UNOIOS, United Nations System Staff College, UNSSC, United Nations University. International health regulations. While disease outbreaks and other acute problems and other acute public health risks are often unpredictable and require a range of responses, the International Health Regulations 2005 IHR provide an overarching legal framework that defines countries' rights and obligations in handling public health events and emergencies that have the potential to cross borders. The IHR are an instrument of international law that is legally binding on 196 countries as international health regulations, including 194 WHO member states. The IHR grew out of the response to deadly epidemics that once overran Europe. They create rights and obligations for countries, including the requirement to report public health events. The regulations also outline the criteria to determine whether or not a particular event constitutes a public health emergency of international concern. At the same time, the IHR requires countries to designate a national IHR focal point for communications with WHO to establish and maintain core capacities for surveillance and response, including at designated points of entry. Additional provisions addresses the areas of international travel and transport, such as the health documents required for international traffic. The IHR introduced important regulatory safeguards to protect the rights of travelers and other persons in relation to the treatment of personal data, informed consent, and non-discrimination in the application of health measures under the regulations. The International Health Regulations IHR, first adopted by the World Health Assembly in 1969 and last revised in 2005, are a legally binding instrument of international law. The aim of the IHR is for international collaboration to prevent, protect against, control, and provide a public health response to the international spread of disease in ways that are commensurate with and restricted to public health risks and that avoid unnecessary interference with international traffic and trade. The IHR is the only international legal treaty with the responsibility of empowering the World Health Organization (WHO) to act as the main global surveillance system. In 2005, following the 2002 to 2004 SARS outbreak, several changes were made to the previous revised IHRs originating from 1969. The 2005 IHR came into force in June 2007 with 196 binding countries that recognize that certain public health incidents extending beyond disease ought to be designated as public health emergency of international concern (PHEIC) as they pose a significant global threat. Its first full application was in response to swine flu pandemic of 2009. Conclusion. That's the end. So the next topic is Global Health Workforce Challenges and Strategies by Dr. I.D. Alabere, MNI, page 880. Outline. Introduction. Current global health workforce situation, current Nigerian health workforce situation, reasons for the global health workforce shortage, strategies to deal with the current crisis. Introduction. Health workers are defined as all people engaged in actions with the primary intent of enhancing health. Health workers are the cornerstone and drivers of health systems and are recognized as an important component of all health systems inputs and a top priority of global agenda. Their availability in adequate number, mix, and proper distribution among the various tiers of healthcare and geographically is essential for the health system of any country to function well. For several decades, there have been critical gaps in the global health workforce in terms of numbers, distribution, competencies, quality, motivation, and performance that prevents progress in reducing maternal and child mortality, controlling communicable and non-communicable diseases, and achieving universal health coverage. There is also increasing awareness that the health workforce challenges affect all countries and at all levels of socio-economic development with varying degrees of severity. Addressing these challenges through the identification of evidence-based solutions is imperative for the achievement of universal health coverage. The Global Strategy on Human Resources for Health, GSHRH, Workforce 2030, emphasizes that health systems can only function well when they have sufficient, well-trained, and equitably distributed health workers who are competent, responsive, motivated, and productive. Health workers shortage in various countries has been documented. Although some global efforts have been made to improve the health workforce, nearly all countries are challenged by large deficits and inequitable distribution of health workers. This is compounded by the lack of accurate data on health workforce that is required to optimally use existing health workers and advocate for investment in the health workforce. Countries worldwide are facing challenges in the education and development of their health workforce, and African countries have been facing long-standing HRH crisis. Current global workforce situation. In 2020, global health workforce was 65.1 million health workers. This is projected to increase to 84 million by 2030. This gave a shortage of 7.2 million health workers. The projected shortage will be 12.9 million health workers by 2035. This ongoing shortage is most intensely felt in developing countries that need them most. Sub-Saharan Africa, with 11% of the world's population, bears more than 24% of the global burden of disease, but has only 3% of the world's health workforce. Africa has a health worker density of 0.8 per 1,000 population, compared with 10 per 1,000 population for Europe. As at 2011, Africa produced 5,100 doctors yearly, while Europe produced 173,800 doctors yearly, which is even insufficient for their needs. There has been growing concerns in recent years, even in the most developed countries, about the growing shortages of health professionals, particularly doctors and nurses. In the UK, shortage of qualified medical staff is crippling the National Health Service (NHS). Current global workforce situation. In 2014, the Global Health Workforce Alliance and WHO reported on the status of the global healthcare, or HWF, based on the data of 186 countries. The report noted that only a few countries had comprehensive and accurate data on their existing health workers, and merely 53% of these had reported annual health workforce data. This shortage was most severe in low-resource settings, including the Africa region, where 36 member states were classified to have health workforce crisis. It was reported that there was a deficit of 7.2 million health workers worldwide, and it is predicted that by 2030, the shortage will grow to 18 million. It's also indicated that 83 countries were below the WHO minimum threshold density of 22.8 health professionals, physicians, nurses, and midwives, close per 10,000 population, in relation to the objective of delivering essential health services of relevance to the Millennium Development Goals, primarily MDG 4 and 5. Current global workforce continued. By 2015, only 11 countries in the WHO African region had met the WHO minimum threshold density of 22.8 health professionals, as physicians, nurses, and midwives per 10,000 of the population. However, there has been an overall increase in the stock of these categories of health workers in more than half, 54% of the countries, but in terms of density, about 23% only have reached or exceeded this minimum threshold. In 2020, the global workforce stock was health professional cadre population millions, nurses 29.1 million, midwives 2.2 million, medical doctors 12.5 million, pharmacists 3.7 million, dentists 2.7 million, other health professionals 14.9 million, total workforce 65.1 million. The 65.1 million health workers were not equitably distributed, with a 6.5-fold difference in density between high-income and low-income countries. The projected health workforce size by 2030 is 84 million health workers. This represents an average growth of 29% from 2020 to 2030, which is faster than the population growth, 9.7%. This projected growth by 2030 in health workforce is expected to decrease shortages in WHO African and Eastern Mediterranean regions by only 7% and 15% respectively. This reassessment presents a revised global health workforce for shortage of 15 million health workers in 2020 and 2020 decreasing to 10 million health workers by 2030, brackets a 33% decrease globally. The projected shortage of health workers in Africa by 2030 is expected to be 6.1 million. This gap has not only hampered the provision of essential health care services to meet the health-related SDGs, but has also constrained accelerated progress towards universal health care coverage, which is SDG 3.8. The African region not only has the lowest number of health workers, but also the lowest density of health workforce and the highest disease burden. This high disease burden and increase in health emergencies through epidemic outbreaks have exacerbated the need for qualified health workers in the African region. Stock of health workers, medical doctors, nurses, midwives, dentists, pharmacists in 2020 by WHO region in millions. So you have Africa region, dentists 0.04, doctors 0.33, midwives 0.25, then region of the Americas 2.49, okay, Eastern Mediterranean region, European region, Southeast Asia region, Western Pacific global. So you can look at it, page 889. Distribution of health workers at a more granular level and the degree of sub-regional disparities, page 890. The projected stock of SDG 3 health workers, dentists, medical doctors, midwives, nurses in 2030 by WHO region. So you can look at it, page 891. Then 892 as well. Estimation of global health workforce shortage in millions, 2013, 2020, and projection in 2013 by occupation. So current global workforce situation continued. This ongoing shortage is most intensely felt in developing countries that need them most. Sub-Saharan Africa, with 11% of the world's population, bears more than 24% of the global burden of disease, but only has 3% of the world's health workforce. Africa has a health worker density of 0.8 per 1,000 population, compared with 10 per 1,000 population for Europe. As of 2011, Africa produced 55,100 doctors yearly, while Europe produced 173,800 doctors yearly, which is even insufficient for their needs. There have been concerns in recent years in the most developed countries about growing shortages of health professionals, particularly doctors and nurses. In UK, the shortage of qualified medical staff is crippling the National Health Service (NHS). This serious shortage of health workers considerably constrained achievement of health-related MDGs in most countries. WHO estimates that 57 countries, 36 of them in Africa, 7 in Eastern Mediterranean, 6 in Southeast Asia, 5 in Central and South America, and 3 in Western Pacific regions were facing a very severe shortage of adequately trained health personnel. The 2006 World Health Report estimated that countries with a density of fewer than 2.28 doctors, nurses, and midwives per 1,000 people generally fail to achieve a targeted 80% coverage for skilled birth attendants and childhood immunization. Nigeria's health workforce shortage was estimated in 2012 to be about 144,000, placing it 7th among 57 countries in their need of health workers. There is a direct relationship between the ratio of health workers to population and survival of women during childbirth and children in early infancy. As the number of health workers declines, survival declines proportionately. The Midwifery Services Scheme was introduced in Nigeria in response to obvious inadequacy of manpower to achieve MDGs 4 and 5 rather. Page 895. Comparison of basic health indicators between the Americas and Sub-Saharan Africa. So the Americas, Sub-Saharan Africa, 14% of world population. Americas, Sub-Saharan Africa, 11% of world population. Americas, 10% of global burden of disease, while Africa is greater than 24%. The Americas, 42% of world health workers, while Africa is just 3%. Americas, greater than 50% of global health expenditure, while Africa is less than 1%. Wow. So, page 896, workforce to population ratios for 186 countries. For page 897, estimated critical shortages of doctors, nurses, and midwives by WHO region. 898 density of medical doctors in West Africa in 2020 by country per 10,000 of the population. So Cape Verde has the highest, followed by Nigeria 3.8, Cote d'Ivoire 2.3, Mauritania 1.9, and okay, so you can look at it further, page 898. So the Nigerian health workforce situation. Nigeria has one of the largest stocks of human resources for health in Africa, comparable only to Egypt and South Africa. As of recent data, Nigeria has a significant shortage of healthcare workers relative to its population. The country has around 74,543 medical doctors and 180,709 nurses and midwives. This number is quite low compared to the actual need for such populous nation, which is about 220 million people. The geographical distribution of health workers in Nigeria is very uneven, with fewer staff per person in less developed areas. There is higher concentration of health workers in urban areas, tertiary healthcare, curative facilities, and the southern parts of the country. The uneven distribution of health workers is greater in some category of workers, like physician specialists being the most unevenly distributed. So, summary of health workforce profile for Nigeria 2012: physicians, registered nurses, pharmacists, lab scientists, physiotherapists. Okay. So, look at it, page 900. Population estimates, health workforce and doctors 2016 to 2030. So, look at it, page 901. Reasons for the Nigerian health workforce shortage. Human resources for health in the country are beset by the following issues and challenges. 1. Shortages, maldistribution, and underutilization of health professionals as a result of persistent brain drain, skewed rural-urban disparity in the distribution of health service providers, and inefficiencies in the rational deployment and utilization of staff on the basis of workload. B. The overall HRH picture in Nigeria is inconsistent and lacks integrity, as HR information and data collection are fragmented and incomplete, with various stakeholders collecting and collating bits and pieces in the absence of any common data source or human resource management information system, HRMIS. C. Production of health professionals are not related to the requirements of the country, there is no mechanism in place to inform health training institution intake and output targets on the basis of service demand and staffing projections. D. There are systemic deficiencies in the planning, management, development, and administration of the health workforce. E. Variations in hiring arrangements as health professionals move from one location within the country to the other. Hiring arrangements in some states do not favor non-indigenous. F. Mobilization, allocation, and utilization of health resources are fragmented among players. Activities of private sector health providers are poorly coordinated. This affects staff development and utilization. G. There are no standards to guide staffing and their utilization for both private and public sector. Whilst worker productivity in the public health sector is very low, many private sector health practices, on the other hand, suffer from poor work quality because of commercial pressures. H. Intakes into training institutions are not informed by projections of staff requirements, resulting in an overproduction of some categories of health workers and a lack of others. The effects of the HRH challenges in Nigeria. 1. Poor availability, distribution, and utilization of the health workforce. 2. Dysfunctional health management system. 3. Demotivation and high attrition among health professionals. 4. Limited attainment of health sector goals. 5. Poor health system performance. The Nigerian Human Resource for Health Strategic Plan 2008 to 2012. So the overall aim was to ensure that adequate numbers of skilled and well-motivated health workforce are available and equitably distributed to provide quality health services. The strategic objectives for its implementation were: A. Provide a framework for objective analysis, implementation, and monitoring of measures aimed at addressing the HRH crisis in the country. B. Rationalize and align supply of health workforce to the priorities of the health sector. C. Apply best practices of human resource for health management and development that promote equitable distribution and retention of the right, quality, and quantity of health human resource to ensure universal access to quality health services. D. Institutionalize performance incentives and management systems that recognize hard work and service in deprived and unpopular locations. E. Foster collaboration among public sector, non-government providers of health services, and other HRH stakeholders. F. Strengthen the institutional framework for human resources management practices in the health sector. Reasons for the global health workforce shortage. The reasons for global shortage in health workforce are numerous, multifaceted, and complex. It is, however, important to consider the following. 1. The factors that produce health workforce shortages are not the same in all countries or in all parts of individual countries. 2. Some factors are common across cultures, even if their local manifestations may vary. For example, in most countries with shortages, there is inadequate funding of health worker education and training. 3. Some of the causes of local health workforce shortages are peculiar due to inadequate planning, financing, and policy. 4. Local shortages can also be caused or exacerbated by conditions in other countries. One country's domestic and foreign policies can significantly affect health worker shortages in other countries. 5. These policy choices are often made without regard for the potential negative impacts on the health workforce in other countries. Governments may not intend to cause harm outside their borders, but public officials may either be unaware of the effects or simply too focused on domestic political concerns. Domestic countries, for example, often rely significantly on foreign-trained health workers. Developed countries, for example, often rely significantly on foreign-trained health workers to staff their health systems. These developed countries do or ought to know that many workers come from these countries that desperately need more health professionals themselves. In designing solutions, policymakers must therefore take account of local causes and conditions as well as other push and pull factors that may be inherent in other countries. The specific reasons for the global shortage in health workforce are 1. Underproduction. 2. Maldistribution of health workforce. 3. Migration. 4. Health workforce exit. 5. Health hazard and violence among health workers. 6. Reduction in duration of service. 7. Increase in demand for health care. Underproduction. Many countries in the world with acute shortage of health workforce face a lack of medical schools, e.g. 2/3 of sub-Saharan African countries have only one medical school and some have none. Generally, the production of health workers is not sufficient even in countries like US, Canada, and UK. These countries rely heavily on foreign health workers. This is evident by the fact that the foreign medical graduates comprise 25% of total physician population in the US. Maldistribution of health workforce. Maldistribution between urban and rural areas and in nearly all countries, e.g. most medical doctors and nurses in Nigeria and Bangladesh are concentrated in the urban secondary and tertiary hospitals, while 70% of the population live in rural areas. Even in developed countries like the US, there is marked disparity in the percentage of physicians working in rural areas compared to the urban areas. Migration and health workforce flight. Migration of nurses and doctors to developed countries is crippling health systems in many poor-sending countries. By 2000, and on average, in the OECD countries, 11% of employed nurses and 18% of employed doctors were foreign-born. Caribbean and a number of African countries have particularly high immigration rates of doctors. For some of these countries, this is combined with very low density of doctors in the home country, highlighting a very worrying situation for the health sector in these countries. Both push and pull factors are operating for this migration. The push factors include 1. Poor remuneration and facilities. 2. Limited career structures. 3. Poor intellectual stimulation. 4. Bad working conditions. 5. The threat of violence. 6. An oppressive political climate. 7. Persecution of individuals. And 8. Discrimination. The important pull factors are 1. Better remuneration. 2. Upgrading qualifications. 3. Gaining experience. 4. A safer environment. And 5. Family-related matters. Push and pull factors that influence health workers to migrate from their country of origin for employment in a new country. Push factors: poor working conditions, poverty and economic instability at home, high crime rates, individual desire for a better life, political instability in home country, war and civil unrest, poor employment and educational opportunities in home country, surplus of health workers in home country, and embargo on employment. Pull factors: strong demand for health workers in destination country. Recruiters usually assist with migration. Promise of better pay and conditions and more opportunities for professional education and career advancement. Agreeable migration policy in destination countries. Apparent ease of movement of information and people around the world. Promise of safe, peaceful, and prosperous life for self and extended family. Colonial language or cultural ties between source and destination countries. Health workforce exit. Substantial number of health workers leave the health workforce due to 1. Poor health, death, and retirement. 2. Some workers leave temporarily in order to attend advanced courses. 3. Poor remuneration and sometimes delay in remuneration. 4. Long working hours and sometimes no holidays. 5. Large workloads and too many patients. 6. Lack of flexibilities for aging workers or workers with family responsibilities. 7. Fear of being unable to care properly for patients. 8. Inadequate equipment, drugs, and other medical consumables. 9. Disorganized health management. 10. Lack of mentoring or supervision. 11. Poor access to training and development. 12. Few opportunities for promotion or career progression. 13. Low morale. Health hazard and violence against health workers. Increasing violence against health workers is prompting more and more health workers to quit their jobs. In Sweden, the health sector is the high occupation at the highest risk of violence. Health workers in conflict areas have been subject of increased violence, false accusation, and sometimes tried and imprisoned. In the absence of appropriate safety guidelines, accidents and exposure to infectious diseases impose huge occupational threats. HIV/AIDS has rendered the health workforce a dangerous place in sub-Saharan Africa, where there are no institutional life insurance for health workers. For example, from 1999 to 2005, Botswana lost 17% of its health workforce due to HIV/AIDS. Health workers constituted over 50% of the EVD deaths in Nigeria. That's Ebola. Kidnapping for ransom, particularly in Nigeria. Reduction in duration of service. Many doctors in developed countries, especially young doctors, are working fewer hours and placing greater emphasis on personal time. Physicians are working significantly less in European countries as a result of European Working Time Directive. Similarly, in the US, the Accreditation Council for Graduate Medical Education regulates the duty hours of medical residents to protect them from overwork and promote patient safety. In Canada, a large proportion of doctors now demand more time for themselves and their families, or their families. Also in Canada, physician workforce has more elderly and females who work relatively less hours. Additionally, earlier retirement trends are getting increasingly common among health workers in Canada. In OECD countries, workforce aging will decrease the supply of physicians as the baby boom generation of health workers reaches the retirement age. Increase in demand for healthcare. 1. Increased utilization and demand for healthcare services as a result of increase in chronic diseases and conflicts. 2. Emergence of new diseases are also placing additional demands on the health workforce. 3. Conflicts often also cause severe and long-lasting damage to the health workforce itself. 4. Population growth, aging population, and advancements in technologies. 5. Increased demand for health worker skills and knowledge in diverse settings, e.g. international agencies and NGOs for programs, domiciliary and home care of elderly and chronically ill patients. Strategies to deal with the current crisis. 1. Efficient use of existing health workforce. 2. Task shifting and task sharing from highly skilled health workers to less skilled health workers. 3. Aggressive retention policies. 4. Development of rural health infrastructure, financial incentives, and social recognition to work in rural areas. 5. Increase in retirement age and protection for staff. 6. Production of suitable health workforce. 7. Balancing the skill mix of the workforce. 8. Develop national and international workforce strategies. 9. The implementation of WHO Global Code of Practice on the international recruitment. The implementation of WHO Global Code of Practice on the international recruitment of health personnel. Efficient use of existing health workforce. 1. Improving management and supervision. 2. Provision of clear job description. 3. Addition of services to pre-existing means of delivery. 4. Continued medical education and in-job training to improve the performance of the workers. 5. Use of telemedicine. Task shifting. We are talking of strategies to deal with the current crisis. I'm still on it. So task shifting from highly skilled health workers to less skilled health workers. WHO defined task shifting as a rational redistribution of tasks among health workforce teams involving moving specific tasks where appropriate from highly qualified health workers to health workers with shorter training and fewer qualifications. Task shifting is an innovative solution to the scarcity of trained, specialized health manpower in low-income countries, as it has been found to offer high-quality, cost-effective care to more patients than a physician-centered model. Countries like Brazil, Ethiopia, and Pakistan that successfully implemented models of task shifting have reaped improvements in the health status of their populations. The government of Pakistan created the Lady Health Worker Cadre in 1994, and by 2005 there were 100,000 trained female community health workers providing essential primary health care services in the community with substantially better outcome and better health indicators. Nigeria has trained and deployed Jews and JHUs in the primary healthcare settings with variable results. In some developed countries, physician assistants are used to perform tasks that were traditionally undertaken by doctors with remarkable success. Task sharing from highly skilled health workers to less skilled health workers. Task sharing is the process of enabling lay and mid-level healthcare professionals such as nurses, midwives, clinical officers, and community health workers to provide clinical services and procedures that will otherwise be restricted to higher level cadres safely. Task sharing entails a systematic delegation of tasks where suitable for more highly skilled professional cadres to less specialized cadres in an order to improve efficiency and maximize use of existing human resources for health. Despite variations in models for task sharing across countries, documented experience suggests that it has potential to vastly improve access to health services with a markedly higher number of health workers empowered and licensed to provide critical care. WHO 2006, WHO 2013. Task sharing. Okay, so it is therefore a vital strategy in overcoming the shortage of doctors in many countries, even in well-resourced health systems. Task sharing offers means of providing services more efficiently, more cost-effectively, and in a less medicalized environment. Task sharing is envisioned to create a more rational distribution of tasks and responsibilities among cadres of health workers to improve access and cost effectiveness. Benefits of task sharing. 1. Task sharing has the potential to increase access. 2. Task sharing has the potential to free up time for doctors and clinicians to spend on their high-level services. 3. Task sharing has the potential to allow you to have more impact without increasing spending on salaries. 4. Task sharing can allow the same amount of services to be provided for less salary spend. Aggressive retention policies. Improvements in poor work. 1. Improvement in poor work environments with assurance of adequate supplies and facilities. 2. Provision of monetary and non-financial incentives to retain them and motivate health workers to stem migration and brain drain. 3. The provision of a stimulating environment and a vibrant intellectual community for professional growth. In Thailand and Ireland, such attempts to improve domestic conditions have succeeded in combating brain gain. 4. Demand for compensation from departing professionals and delaying their departure through compulsory service for those who were trained on government scholarship to work for a specified period in government-run hospitals after their graduation. Development of rural health infrastructure, financial incentives, and social recognition to work in rural areas. This will assist in attracting and retaining health workers to rural areas. These strategies have been successfully applied in Thailand. Recruitment of students from rural provinces, subsidized education and training in the rural health facilities, and hometown placements after graduation have contributed to the successful distribution of graduate doctors, nurses, and paramedics in rural health centers and district hospitals. In U.S., medical school rural programs with the policy of enrolling students from rural backgrounds and the provision of extended rural clinical curriculum have been shown to produce a remarkable increase in the rural physician supply. Increase in retirement age and protection for staff. Early retirements can be discouraged by providing incentives to work longer. The present retirement age for health workers should be reviewed upwardly as currently advocated for some European countries. Protection of the health of health workers, including access to effective HIV prevention and treatment, is also extremely important. This will encourage them as well as reduce premature mortality and absenteeism from work. Provision of adequate protection with guarantees for health workers serving in conflict areas. Production of another subtopic under strategies to deal with current crisis. Production of suitable health workforce. With the shortage of over 7.2 million, increased education and training of health workers is fundamental to resolving the crisis. This will need careful workforce planning and mobilization of financial, technical, and human resources to train health workers. Workforce development has to be data-driven. Assessment of performance gaps in health workers will be an invaluable tool in identifying the categories of workers needed to meet priority healthcare needs of each country, and as is currently done in most developed countries. Establishment of new health manpower training institutions and increasing the carrying capacity of the existing ones based on the assessment of the performance gaps. Balancing the skill mix of the workforce. 1. Many countries have the skill imbalances with a preponderance for doctors and specialists. These countries must accept to generate a workforce that more closely reflects the health needs of their populations, especially through deploying middle-level health workers Middle-level health workers including clinical officers, assistant medical officers, midwives, surgical technicians, and physician assistants have proved to be very useful in many countries. In US, there are more than 44,000 physician assistants who work with physicians and perform many of the tasks previously done solely by their physicians. These physician assistants have improved access to healthcare for populations in rural, inner city, and other medically underserved areas. Similarly, middle-level health workers in many African countries like Ghana, Zambia, Tanzania, Mozambique carry out tasks internationally recognized as those of other professionals, including surgeries. Training middle-level health workers whose qualifications are not recognized outside the country is not only more feasible but also addresses the issue of brain drain to some extent. This has been the practice in the British, Royal, and Nigerian Armed Forces Medical Services. Develop national and international workforce strategies. Every nation backed by appropriate international reinforcement should work towards development of workforce strategies specific and appropriate for the needs and situation of the country. A national health workforce development policy and plan must be formulated to 1. Project the country's long-term health workforce needs, identify strategies to meet those needs, including creating an educational infrastructure, attracting people to health careers, and ensuring employment opportunities for successful graduates. 2. Build the capacity to react to short-term crises and be adaptable to changing circumstances. The plan should be accompanied by a health workforce expenditure component that coordinates and guides resource allocation. Develop national and international workforce strategies continued. Strategies also have to be developed by every country to more actively engage communities and to secure intersectoral coordination in the process of planning and implementation. This will require political commitment and shared vision between all the involved stakeholders. International partnership and cooperation between several national and multinational agencies and development partners will be essential to solve this global situation. The implementation of the WHO Global Code on Practice on the International Recruitment of Health Personnel. The key points of the code are: A. International recruitment of health personnel should be conducted in accordance with principles of transparency, fairness, and promotion of sustainability of health systems in developing countries. B. Member states should strive to create a sustainable health workforce and work towards establishing effective planning, education, and training and retention strategies that will reduce their need to recruit migrant health personnel. C. Effective gathering of national and international data, research and sharing of information on international recruitment are needed to achieve the objectives of the code. Implementation. D. Member states should facilitate circular migration, circular, CIR, migration of health personnel so that skills and knowledge can be achieved to the benefit of both source and destination countries. E. Destination countries are encouraged to collaborate with the source countries to sustain and promote human resource for health development and training. F. Member states should use this code as a guide when entering into bilateral, regional, or multilateral agreements to promote international cooperation and coordination on international recruitment. G. Member states should consider adopting measures to address the geographical maldistribution of health workers and to support their retention in underserved areas. Adoption of WHO Global Strategy on Human Resources for Health Workforce 2030. The GSHRH Workforce 2030 was developed to accelerate progress towards universal health coverage and sustainable development goals by ensuring equitable access to health workers within strengthened health systems. It has an overall goal of improving health and socioeconomic development outcomes by ensuring universal accessibility, acceptability, coverage, and quality of the health workforce through adequate investments to strengthen health systems and the implementation of effective policies at national, regional, and global levels. Objectives of the GSHRH: 1. Optimization of the existing workforce. 2. Anticipate and plan future workforce requirements. 3. Strengthen individual and institutional capacity. 4. Strengthen the data, evidence, and knowledge. Maintaining a national health workforce account. The concept of National Health Workforce Account (NHWA) is part of the Global Strategy on Human Resources for Health. It was conceived to create a harmonized, integrated approach for annual and timely collection of health workforce information, improve the information architecture and interoperability, and define core indicators in support of strategic workforce planning and global monitoring. The purpose of the NHWA is to facilitate the standardization of a health workforce information system for ease of operation, as well as to support tracking HRH policy performance towards universal health coverage. The NHWA is built up of core indicators and data characteristics that can be progressively measured in order to A. Generate reliable HRH information and evidence, B. Enable the planning, implementation, and monitoring of workforce policies towards universal health coverage, C. Improve the comparability of the health workforce landscape nationally and globally, D. Enable more research to be performed about future trends regarding health workforce systems and resilience planning. Benefits of a national health workforce account. 1. A better understanding of the health workforce, including its size, characteristics, distribution, and thus enable countries to generate insight into the needs and possibilities for strengthening their health workforce. 2. High quality information on the health workforce that informs evidence-based policy decisions according to country needs. 3. A stronger health workforce through identifying significant improvements in health service coverage and health outcomes, especially if causal links with health system characteristics can be established. 4. An ability to guide and inform the transformation and scale-up of health workforce education and training in support of universal health coverage. 5. Strengthen policies, strategies, and plans through intersectoral policy dialogue among the relevant ministries that may include ministries of education, health, and finance. 6. Cross-cutting investments in all aspects of national health workforce accounts that will foster the demands of data-driven plans and policies and capacity building. 7. Improved measuring and monitoring of health workforce trends, systematic research on health system development, and resilience planning. Benefits of a national health workforce account. The NHWA can contribute to finding answers to the following major policy questions related to current HRH challenges and how to optimize planning. 1. Is the current health workforce available, accessible, acceptable, and of appropriate competencies to provide good quality health services? 2. What are the trends in the current health workforce in terms of production, education and training institution output, inflows and outflows, deployment trends, skill mix, equity, gender distribution, foreign trained/born health workforce, etc. 3. What are the current gaps in terms of quantities and by cadre, equity and skill mix, deployment, productivity and performance? 4. Can the current gaps be partially addressed by improving performance through better allocation of resources, through increasing productivity, through effective retention policies, through effective public-private partnerships, etc. 5. Can the current gaps be partially addressed by increasing investments in education and production, increasing immigration, etc. 6. How can policies and strategies aimed at improving performance and increasing inputs be financed, costing of policies and strategic options, including investments and recurring costs, salaries, negotiations with government, ministries of finance, education, labor, as well as negotiations with the private sector. 7. Can the national production of health workers replace the health worker loss caused by exits? 8. Do financial incentives for health workers to settle in underserved areas lead to a more balanced geographical distribution of the health workforce across the region or country, or region? Conclusion. Thanks. So this has ended. This slide has ended page 936. So in the next voice, we'll start with page 937, evaluation of health programs, and that should be the final slide. Okay, so thanks. This has ended at page 936.